Welcome to our first pediatric radiology session, chest section, pulmonary sequestration. By definition, pulmonary sequestration is a dysplastic and non-functional lung tissue which has no communication with bronchial artery. It has two types, extralobar and intralobar. Epidemiologically, extralobar type have a male predilection of 4:1 compared to females, and intralobar affects both males and females equally. Clinically, these patients present due to its type. The extralobar type is commonly present in newborns with distress, cyanosis, or infection. In intralobar type, patients present in late childhood or adolescence due to recurrent pulmonary infections. Embryologically, interlobar type is considered to be an acquired entity. However, extralobar type has a true congenital origin. Pathologically, intralobar type has a pleural covering with drainage to pulmonary veins. Extralobar type has no pleural covering with drainage to systemic veins. But both have a common point, which is receiving arterial feeding vessel from the thoracic or abdominal aorta. By location, extralobar type almost always occur in the left lower lobe, and in few cases in the subdiaphragmatic regions. Intralobar type is seen in most of the cases in the left lower lobe, in 60% of cases around, and in 40% of the cases in the right lower lobe. Radiologically, CT scan is the preferred method, which can reveal arterial and venous supply, and is considered equivalent to digital subtraction angiography, and considered superior to ultrasound and MRI due to overcoming some limitations. Plain radiograph can reveal persistent cystic basal opacity. However, in the very first hours after delivery, a triangular opacity can also be seen. Ultrasonography antenatally can reveal echogenic mass, and in some cases, since it's operator dependent, can also detect the arterial supply by color Doppler ultrasound. In MRI, there is going to be high T1 and T2 signal intensities of the lesion, and angiography can help the vessels. This is the sonogram coronal view, which shows the right hemidiaphragm, right lung, heart chambers, and this is the left lung. This is the well-defined echogenic mass located in the left lower lobe. This is a coronal view with color Doppler ultrasound showing the abdominal aorta, which shows color flow, and there is also extension of the color flow to the lesion. The same patient postnatally after delivery shows that well-defined echogenic lesion in the left lower lobe. In the color Doppler ultrasound, it shows that there is an extension of the vessel to the lesion. This is a coronal view of an adult patient, showing a dysplastic segment of right lower lobe, and there is an extension of a vessel, arterial vessel, feeding vessel, from the upper thoracic aorta, well annotated in this image as well. This is another adult patient, frontal projection chest X-ray, showing a subtle radiodensity in the retrocardiac space. Coronal view contrast enhanced image shows a partial enhancing lesion in the right lower lobe, adjacent to the thoracic aorta, with its feeding vessel coming from the thoracic aorta. This is the axial section of the same patient, showing mass lesion adjacent to the aorta with its feeding vessel coming from and reaching the lesion. This is a 20 months old infant. Shows a subtle radiodensity in the right lower zone. However, right cardiac border is not silhouetted. Here in the axial section, contrast enhanced image of the same patient shows hyperinsulation in the superior segment of the right lower lobe with a feeding vessel coming from the thoracic aorta. The same patient showing a draining vessel vein to the pulmonary vein. Treatment of the patient is surgical resection in symptomatic and asymptomatic. However, the surgical management of the in asymptomatic patients is debatable, Thank you very much. These are the references.